without further ado, we can ask Dr. Michael. I'm sending it back to you, okay?
Thank you so much, Eyal, for that wonderful introduction. So my name is Michael Mamouni. I'm a second-year cornea fellow at the University of Toronto, and as part of this 2-year fellowship, we get to work with several excellent supervisors and learn a variety of approaches to dealing with endothelial keratoplasty. Today, together with Dr. Neeraj Singhal and Professor David Rootman, I'd like to go over a few scenarios of complex DMEK. These are my financials. None of them are relevant to this talk. Currently, corneal endothelial decompensation is the leading indication for keratoplasty. DMEK and DSAEK are the most popular treatments for these cases. Studies comparing DMEK and DSAEK
I lost Michael's vocal audio.
I lost him as well. So,
Michael, we lost you for a while.
we can't hear you.
We can't hear you.
Michael, maybe try to log off and log on.
Can you hear me now?
Yeah.
Yeah.
Wait, I just had to disconnect, reconnect. Don't know what happened. Sorry about that. So examples of technically challenging DMEK cases include eyes with deep anterior chamber.
You got to restart your screen too.
You can't, you don't see my screen anymore? Sorry.
Hall, why are you wearing a mask? You're isolated. Ah, I see. Hi, Stefan.
So examples of technically challenging cases include eyes with deep anterior chambers, such as vitrectomized eyes, and high myopes, which are difficult to shallow, leading to difficulties in unfolding and centering the graft. Additional examples of eyes where DMEK can be technically challenging are those with lack of diaphragmatic support, such as a large iris defect, aniridia, or aphakia. In addition, eyes with synechia may lead to difficulties in unfolding the graft, and limited visibility and eyes with a prior trabeculectomy or glaucoma drainage devices can also be technically challenging. I'd like to present a few complex cases and how we opted to deal with them surgically and to discuss all of the available options. The first case is a case of a 62-year-old female with posterior polymorphous corneal dystrophy in both of her eyes. She's a frequent flyer in our clinic, having undergone 4 full-thickness transplants in her left eye and sees relatively well from that eye. She noticed that in the last few months, her vision is getting cloudier in the morning in her right eye. Upon examination in her right eye, she is 2300, pinholing to 2100. And on her last visit a year ago, she was 2060 in that eye. She has diffuse microcystic edema, thickened cornea, inferior and superior paracentral iridocorneal adhesions with a discoic pupil and a cataract. Just to summarize, she clearly has a decompensated cornea in her right eye, secondary to PPMD with a cataract. At this point, Nizar, if you could please help, I'd like to bring up poll number 1. The question being, what would you do for a patient with PPMD, iridocorneal adhesions, decompensated cornea, and a cataract? Do we have the poll, Nizar?
I think Nizar was saying something about his
panel. I'd like to see, for instance, what the Dr. Chu and Dr. Singhal would opt for in a patient like this with decompensated cornea, secondary to PPMD, and a cataract.
Michael, I think you are still the host. Could you? I've lost control for the polls.
You've lost control for that?
Yeah.
Let's see. I have no idea how I can do this while sharing.
Maybe in the interest of time, just ask
Here, I got it.
our panelists what they would do in this circumstance.
There we go. I've launched the poll for you, Nizar, no problem.
Okay, great.
So the options are, this patient with PPMD and a decompensated cornea with a cataract, what would you do? Would you do DMEK, lysis of adhesions and a phaco? Would you do a DSAEK, lysis of adhesions and a phaco? Would you do a PKP, lysis of adhesions and a phaco? Or a stage procedure, phaco first with IOL insertion and perhaps a keratoplasty performed at a later date, or vice versa? And last option, would you maybe do nothing because this eye is too complicated?
If I could throw in something while people are doing their poll, this woman has two sons who I operated on when they were, one was 3 and I think the other was 18 months old. And with PPMD, sometimes the parents have it very mild. In this case, she eventually decompensated, but sometimes all you'll see in one of the parents is a little bit of snail tracks, and yet the child is born with diffuse corneal edema that requires transplantation. And so both are boys. Now their boys are in their 20s, and they're still walking around with the same transplants that we did on them many, many years ago.
Is it clicking? There's some.
I think it's always, if you can, my preference is to offer them one surgery as opposed to staging it. I'd probably do a combined approach with DMEK and phaco and lyse the adhesions intraoperatively. As long as I can control the pupil, that I should be able to, I think that would be a fairly straightforward case, but interested to hear what other members of the panel would do.
All right.
I agree with Nira's comments, to try to do it all at once if you can. Trim the tube shunt, deepithelialize the cornea. There's nothing wrong with doing it in a staged procedure, especially looking at the iris the way it is, because there may be some fibrin that comes. Maybe do the cataract first, and you may need to use some iris hooks to pull back the pupil to make the pupil large enough, and then do the DMEK at a later date. But I also ask what the other people would think about doing a PI in this case, because it looks like the iris is very kind of unforgiving. Maybe an inferior PI may be necessary.
Okay, Michael, you want to proceed, or? I think we lost the sound again. I think Michael forgot to pay his internet bill this week. Sorry, folks, we're having Zoom indigestion, I think. Well, I see on our list of participants, we have some residents, ex-residents. I see Alfred Basilios is joining us from Quebec City, and it's nice to see his name up there. And of course, some people from even farther away. I see Dr. Chung from Malaysia is visiting with us today, which is really nice as well. And of course, there's many other people here from all over. Modi Naftali from Israel, a good friend.
Sorry about that earlier. Can you hear me now?
Yeah.
I don't know what's going on. That's never happened before.
So pay your Rogers bill.
I did. I paid it on time. Okay. Oh, well. So in our series, there was an average improvement of 5 lines in visual acuity in patients with corneal decompensation secondary to PPMD that underwent DMEK, and all eyes improved in visual acuity, and all procedures were uneventful. So based on prior successful experience with DMEK in these cases, our surgical plan was to perform synechiolisis followed by phaco-IOL surgery aided with iris hooks and vision blue, followed by DMEK. And now the fun part, the video from that surgery. When it comes to DMEK graft preparation, in general, you want to always aim for a double scroll. That is especially true for complicated cases. Simply put, a double scroll will make your life much easier. You can see me here trying to gently encourage the scroll to go into a double scroll formation. Once that is achieved, you want to try and maintain that double scroll throughout the rest of the process of preparation. You want to use the WEC cell at the north and or south pole of the scroll when drawing VSS to avoid unfolding it. Next, when you perform staining with vision blue, you want to instill the drops away from the graft, again at either the north or south pole of the scroll. In this particular case, we stained the graft for a full 3 minutes, knowing that it was complex. We decided to remove epithelium in order to improve visualization. Next, we used the viscoelastic cannula to break the radial-corneal adhesions using a sweeping motion, first on one side and then on the other. We repeat the sweeping motion until we're satisfied that we've broken all of the adhesions. Next, we placed iris hooks in order
Until Michael gets back online, you can see that we're doing the phaco through. The visualization wasn't bad once we removed the epithelium. And this is the insertion of the lens. And of course, every time you stretch the pupil with iris hooks, you tend to get some breakdown of the blood aqueous barrier with release of fibrin and other proteins that can later complicate your DMEK and complicate the post-operative course as well. And now we're back to the blue screen. Michael, are you back with us, or are you?
hopefully I am.
Okay.
Can you hear me now?
Yep.
Sorry about that. I have no idea what's going on today. So I think we stopped at the desmodorexis. So you'll see, where were we? That we're performing our desmodorexis 360 with the reverse Sinski. And especially in these cases, you want to avoid causing stromal scars. So you can use a 90-degree scaper that we often use for routine cases, especially the complex ones. And we also decided to stain with vision blue to make sure that we don't have any remnant tags of a Descemet's membrane, which we remove after that with the intraocular forceps. You can even use the air bubble to aid in visualization in order to identify any remnant tags. After we're satisfied with the removal of Descemet's membrane, we proceeded with the graft insertion. And you want to make sure that your anterior chamber is shallow enough to avoid having the graft eject from your main wound when exiting the eye. We decided in this case to suture the main wound in order to have better control of the anterior chamber depth. Next, the DMEK unfolding dance begins. We identified that the graft is upside down and use short bursts of fluid in order to try to flip it. First attempting from one side, then from the other. We repeated this several times and were unable to get it to flip into a convenient configuration. We finally have a good configuration, but the graft is off center. So you're going to see that we inject a small air bubble to secure it in its current orientation. The dot to the top right of the line, which can barely be seen, indicates correct orientation, and desperate times call for desperate measures. So we insert an anterior chamber maintainer again, and use the MST forceps to center the graft. The small air bubble ensures that the graft remains in correct orientation, and the maintainer is preventing our AC from collapsing while we do that. Now that we're satisfied with the orientation and centration of the graft, we use a 30-gauge needle to enter below the graft and fill the AC with air. And that concludes that case. So a little riddle, and I'll ask Nizar to bring up poll number 2. At this point, I'd like to ask you, what do you think? How did the patient look one day after that complicated surgery? Do you think that the DMEK is 100% attached with no complication? Do you think that it's partially detached with no complications? Do you think that it's partially detached with a very anticipated complication? And do you think that it's completely detached and now the patient's waiting for a DSAEK? What do you think, panel? Dr. Rubin isn't allowed to answer because he might remember.
Yeah,
Eyal, what's your bet?
hard to forget cases like this.
I think that if you are presenting it, it must be very interesting. So I would guess that she was detached afterwards. I'm not sure if it's complete. I would say that it was partially detached and then you kind of rebubbled it and maybe rebubbled it twice and finally she is attached at the end. But this is my hunch.
All right. And Nizar, you want to take a jab or you want to share the poll? Oh, here we go. So a third of you thought it was partially detached without complications, and equal tie was partially detached with an anticipated complication. So just to move forward, the next day she did have a complication, and at her post-op day 1, we encountered a familiar scenario that we've ran into in the past. In addition to an expected total epithelial defect, the graft is detached centrally and intranasally with fibrinoid reaction and fibrin pulling at the graft. Probably the combination of the synesthesiolysis, the use of the iris hooks, and the prolonged surgery, they all led, in fact, to Dr. Rubin and I looking at each other at the end of surgery and saying almost simultaneously, she will have fibrin in the AC tomorrow. So what would you do next? And that'll bring up poll number 3. You have a post-operative day 1 after a complex phaco DMEK with fibrin in the AC pulling at the graft with a partial detachment. Do you give them Durezol, a strong steroid, every hour? Do you attempt to rebubble? Do you give them Pred Forte, also strong steroid, not as strong as Durezol, QID, which is basically our routine treatment after these cases, with an antibiotic, of course? Or do you rebubble and combine that with intracameral TPA to try to break the fibrin pulling at the graft? What do you say, Nizar? You want to share the results or maybe ask the panel?
Yeah, I'm a little bit biased by this case because I'm aware of it. But if I wasn't aware, I would have done hourly steroids, try and calm the inflammation down, and then attempt to rebubble. But let's see what the audience say.
So I think maybe the audience knows me a bit. So I see that in first place, 58%, we have rebubble with intracameral TPA, and second place would just to go for a rebubble, closely followed by Durezol, and then afterwards Pred Forte. And I wonder what Dr. Chu or Dr. Singal would do in such a case. Would you give that a shot as well?
So I probably would have, I've not had any experience using TPA for this. One thing I've done before is if the cornea is clear enough, I can do a YAG vitreolysis to try to get, if it is just I see the fibrin there, or not vitreolysis, sorry, a fibrinolysis if I could. But I think that's probably the best bet is to use the TPA and gas, like you said. Interesting to see how you guys did it.
Thank you very much, Dr. Chu. It's an interesting thought to try to YAG it. So in this case, we've actually, given our prior experience with TPA for fibrinoid reaction post-DMEK, I think we've got 4 or 5 cases by now. We did opt for a TPA and rebubbling. And following uneventful TPA and rebubbling, we started Durezol every 2 hours as well as atropine. And The following day, the DMEK is completely attached. There's minimal inflammation in the AC, and she still has a nice air bubble of 50%. So this happened to be one of the 4 or 5 cases we have where we've had a positive result using that combination. And at 1 week post-treatment, she has a shallow and less than 20% detachment infranasally, but there's no fibrin, so we decide to observe. She did notice that her vision in her other eye, the left eye, the one with the PKP, had a sudden drop. And hoping that this was a rejection as well, not failure, we started her on Durezol every 2 hours in that eye as well. And at 1 month post-treatment, her vision in her right eye is improved to 20/50. The DMEK is attached and clear other than a little bit of edema inferiorly, and her left eye has responded well to the Durezol treatment, indicating that that was probably a rejection episode. We currently have 3 months follow-up on her, and she does remain stable with this visual acuity in both eyes. For the second case, I'd like to prove, using vigorous scientific method, that jinxing is a real thing. I was operating under the supervision of Dr. Neera Singhal, and we had just gotten back from the winter break. And to be honest, I was a bit anxious after not operating for a few weeks. We had 4 DMEKs booked that day, and the first 3 went smoothly, and we were enjoying a calm and great day. So of course, I had to make a rookie mistake and blurted to Dr. Singhal, "Wow, everything's going so smoothly today. I think we can finish by 2. What a rookie mistake." So that 4th case was a 65-year-old male with PBK and no known other prior ocular procedures other than phaco surgery. Here is his surgery. This eye seems like a straightforward PBK. After marking the outline of our descemetorrhexis, we insert our anterior chamber maintainer. With the aid of the anterior chamber maintainer, we perform our descemetorrhexis 360 degrees through a paracentesis using the reverse Hinsky. Afterwards, we inject our double-scrolled DMEK graft using the Guder glass injector. Before exiting with the Guder through the main wound, we again make sure that the AC is shallow enough in order to avoid graft expulsion when exiting. We then carefully hydrated the wound of our main incision to avoid leakage and have better control of the AC. Afterwards, again, the DMEK tapping begins. With a nice double scroll like this, tapping downwards, aiming at the center of the scroll, will usually lead to it unfolding nicely. After a few taps, the scroll is asymmetrically opened and decentered. So I'm attempting to recenter it and then unscroll it by holding it down with one cannula on its open half and unrolling it with the other cannula using the Dirisamer technique. However, the AC is too deep and I'm unable to get it to unfold. We're able to shallow the AC by constantly emptying it through the paracentesis, and this leads to the graft unfolding, as you'll see shortly, and for a brief moment, it's partially engaged in the wound of the paracentesis. A few taps releases it. Now it's almost completely unfolded, but it's difficult to get it to unfold when it's decentered. So I'm trying to get it centered again, and I probably would have been better off either inserting a small air bubble at this point to lock the graft, but instead I tried to center it. As I'm doing so, the AC continues to deepen, and the graft again begins to form a scroll. So again, I'm trying to center the scrolled graft, and we're trying to shallow the AC, and at the same time tapping the graft in the center to get it to unfold. However, the AC still remains deep. With the AC constantly deepening, we started to wonder if this was perhaps a vitrectomized eye, since it seemed to be behaving that way. You can see the DMEK formed a taco formation, and tapping that would be futile, so we injected pulses to try to get it to form a different and more friendly configuration. Finally, we get the graft in the correct orientation and a more friendly configuration and are able to get it to unfold. At this point, we both look at each other and say at the same time, "Small air bubble." This locks our graft in and allows us to improve the centration. You'll soon see that the eye was so soft that it creates negative pressure and sucks in our air bubble into the vitreous. Luckily, we were able to center the graft enough and get it in the correct orientation and then fill the AC with air and conclude the case safely. So what are the take-home messages from this case? I think that we've clearly demonstrated that OR jinxing is a real thing, so please think twice before speaking. This was a nice example of how it may be difficult to unfold a graft in a deep AC, especially if you're not expecting it. The assistant's job of managing the AC depth is always important, but in these cases, it's absolutely critical. It took 2 cannulas emptying the AC and another 2 unscrolling the graft to get it to unfold. Once sufficiently unfolded, inject a small air bubble to secure the graft. The air bubble can be used then to unfold the rest of the graft and even center it if needed. And at this point, I'd like to bring up poll number 4. What is your preferred method of DMEK in vitrectomized eyes? Option 1, no thank you, waiter. I'd like to order an ultra-thin DSAEK, please. Option 2, Parse Plana Infusion assisted DMEK. Option 3, pull-through DMEK techniques such as a tri-folded or using a tan endoglide. Or piece of cake, I just use my regular DMEK technique for these cases. I know what I choose. I'd like to ask the panel, who shall we ask? Maybe we can see Professor Slomovic, are you on the line?
I certainly am. First of all, I'd like to congratulate you on 2 excellent cases with beautiful outcomes, very challenging. All of those who've been there know how, DMEK, when it goes well, goes very well. But when you have these challenges, it really separates the air fluid from the vitreous. Can I just make first of all, about this, I have not done this as of yet. I would have gone for ultra-thin DSAEK. But we're looking at getting the tan endoglide. And I think if you can do a pull-through technique with a deeper, with a vitrectomized eye, that may be a preferable way. I'm sure there's lots of ways that work, but I don't have any experience with that yet, but I hope to have that soon. I want to just bring something up. May I bring something up about the last case, or have we gone beyond?
Yeah, sure.
Okay, so, it's a question I ask myself. When you have a PKP that's failed, when do you do another PKP? When do you do an ultra-thin DSAEK? When do you do a DMEK? And I think my rule of thumb has been, if the patient has been happy with their vision before the graft failed, then I would do an endothelial keratoplasty. So I think the fact that, just remind me, you got to 20/50 by refraction, correct?
We're talking about the first case or the second?
Yes, first case.
The first case with the PPMD. So she was 20/60 before her cornea decompensated, and she dropped to 2300 pin holding to 2100.
Okay. The interesting point, but she was 20/60, which is functional vision. I mean, you're one line away from driving vision there, and that could go in either way. So I think that certainly is an indication to do an endothelial keratoplasty, and then whether I'm going to beg this question because I think it needs to be asked. If you have an eye that is not have 20/20 potential, do you want to do a DMEK? It came out beautifully, so obviously it can be, and congratulations to you and to Dr. Rootman. I think that's a beautiful case. But for the other mortals on the line, would, if you're not going to achieve 20/20, and you're laughing, I was going to ask this question. If you're not going to achieve 20/20, are you, there is a slightly reduced incidence of rejection. So that's one thing in the favor of a DMEK, but I think that's a question we all have to ask ourselves. Would we have had the same amount of fibrin, and would it have had the same impact on a tissue that was like an ultra-thin DSAEK? I think the vision would probably end up the same. And I'd like to open that if anybody has any comments. I think it's something, we don't have good evidence, we just have our experience, and that's what I love about these rounds is we can share our ideas.
Professor Rootman, would you like to comment?
Well, I think there were 2 eyes in that patient. The left eye was the one that had the previous multiple transplants, and she at the time of doing her second eye was doing relatively well with a vision of 20/50, 20/60. The right eye had deteriorated due to the PPMD advancing, and she had not had a previous graft in that eye. So So it wasn't, we weren't doing a DMEK on a post-graft patient. This was a virgin eye that had not been operated on before. So I think when it's a virgin eye, you know, I try and go for the best, and if possible, you know, if there aren't other considerations. I mean, if the patient truly has 2200 vision and it's going to be an easy DMEK, I would do the DMEK. But if they got 2200 vision and they're aniridic or something like that, then you know, probably 2 years ago, I would have still tried to do a DMEK, but now I've become a little wiser and would opt for an ultra thin DSAEK instead, or even a regular DSAEK. So really, it depends on the whole circumstance. And in that lady, I didn't see any reason not to do a DMEK, and certainly we thought of her potential. She's only a couple months out, but we think her potential is better than 2050, and we hope she'll eventually achieve that. So, but it's not a simple answer. You know, I agree with you completely. In a previous graft, it depends on how much astigmatism they had and how regular the cornea was, whether you're going to do an EK or a PK.
And these, I think, David, are the conceptual thoughts that we all have when we're looking at these complicated eyes, these whether we're going to do ultra thin DSAEK, whether we're going to do a DMEK, either on an eye like this. But clearly the results are excellent. So I mean, that's great. But I think there are a lot of issues that I ask myself. You know, whether I would. Which operation I would do.
Right, of course, that's what it's all about. But, you know, let's say you had a patient whose best visual potential was 2060. Do you want to do a DSAEK that might only get them to 2080? Maybe those 2 lines of vision are going to make a big difference for that patient. So
I think, David, when you're looking at ultra thin DSAEK, I think you know, the studies are showing that you're getting comparable results. I mean, you're getting, you know, we've had a couple of 2020s, and I think in the literature, you'll find that there are 2020s. However, you know, there is a slightly increased risk of rejection, DMEK versus DSAEK. So that's favoring DMEK. More rebubbling. And we know we lose cells whenever we rebubble. Fibrin is a big issue where it's really, if you're doing an ultra thin DSAEK, it's not that much of an issue. Whether the patient is coming from afar, it's difficult to get in. I think it all goes into the computation, and then I think this is what is enjoyable about these rounds is you have people with experience who can talk about what their experiences are, and you know, obviously it was a beautiful outcome. Yeah.
We have Dr. Goodman who raised his hand. If you could unmute yourself and ask your question, please.
Dr. Goodman, can you pipe in? Are you still there?
Still unmuted. Perhaps you'll come back later.
He can write it on chat, and then you could ask it, Nizar.
Yes, I've asked, but okay, we'll continue.
All right. So we'll move forward now for the sake of time.
Mm-hmm.
All right. So a few words about Plana Infusion assisted DMEK, for which we reported preliminary outcomes 4 years ago. Plana Infusion is a powerful tool for vitrectomized eyes, which tend to have ACs that simply refuse to shallow. With the foot pedal controlling the infusion line, the surgeon can reduce AC fluctuation and avoid excessive deepening. Furthermore, the surgeon can increase the pressure of the eye at the end of the case to promote graft adherence in a sealed eye. Here is an example of a patient who underwent previous vitrectomy for retinal detachment secondary to high myopia. So this patient has 2 reasons for a deep AC, high myopia and a vitrectomized eye. And no matter how much we tap the graft and try to shallow the AC, it keeps on scrolling up again into a double scroll before we're able to get a small air bubble underneath it to secure it. So this was actually my first pars plana infusion assisted DMEK with Professor Ruthman. We used a short burst of fluid to get the graft to unfold just a bit more, and then turn the infusion line on in order to shadow the AC. Now, a few taps on the center of the graft are enough to get it to unscroll just enough. Now we need to hurry before the fluid from the infusion migrates anteriorly and our AC deepens again. All we need to do is get that small air bubble in to lock the graft. A great way to avoid injecting too much air is emptying your syringe all the way down to 0.3 cc of air. Once the air bubble is in, we can now unfold the rest of the graft with a few gentle taps. That air bubble helps us secure the graft and prevent it from decentering and re-spooling. Next, we want to seal all the wounds, as we will soon use the infusion line to increase the pressure, so we throw one suture on the main wound. Next, we fill the rest of the AC with air, and then raise the pressure of the infusion line to get a firm eye. And then finally, fill the AC to 100% air to conclude the case. Prof, would you like to comment or provide pearls regarding the use of pars plana infusion for DMEK?
Sure. As you do more and more DMEK, you acquire more tools in your tool bag that you can use in these situations. And the one that I got from Frank Price was that you try and sometimes what you have to do if the chamber's deep is just keep swirling it with short pulses of BSS until you get the trifold kind of configuration. And then once you got that trifold, that will usually hold an air bubble. And the trick is to go underneath, but don't just, well, expel all the air except for 0.05. So it's just a teeny tiny bit of air left in the 1 cc syringe. And then put the cannula underneath and lift up with your cannula. You'll probably lose a few endothelial cells doing that, and then inject the air. Because otherwise the air bubble on the trifold may end up flipping around and not pushing up on the membrane to hold it into place. We also showed that we had quite a few retinal detachments in our group as well. So I'm not as cavalier about putting in posterior infusion, and Ayal pointed out to me about a week ago, and I think it makes good sense, is that there some retina people, his boss in particular, has said, if you're not going to go in there with a biome and with and do a complete vitrectomy, you shouldn't be going in there at all. And that's sort of rang home true. Now, it's not to say I won't use it in the future, but I'm trying to utilize other techniques as well in these cases. But if it's a patient who's had a good vitrectomy in the past, or if you can work with a retina person that can go and look at the infusion site afterwards, then I think it's a great way to help control the AC depth.
Thank you for the great tips and pearls. And on that thought, I'll give now another fourth example. Last case, we have a 30-year-old female with a history of JIA iritis in both eyes since childhood, which is now under control. She has a failing DSAEK in her right eye, and her vision has slowly dropped from 2030 to 2060 in the past 2 years. You can see that she has a glaucoma tube supratemporal and a large PI, as well as an irregular pupil. In the last year, her pressure is well controlled, ranging from 5 to 10. And did I forget to mention that this is, of course, for better eye? So let's bring up poll number 5 while we discuss with the panel what they would do in such a case. You have a 30-year-old female with history of JIA iritis, failing DSAEK on her right eye with 20/60 vision, a glaucoma tube, large PI, and a regular pupil. What would you do? Option 1, she should say thank you that she sees 20/60 with such an eye, observation only, aka Muro. Option 2, repeat DSAEK using an ultra-thin graft. Option 3, repeat DSAEK combined with a pupilloplasty, a DMEK, or DMEK with pupilloplasty. So let's see.
She's virtually blind in the other eye. She has no vision in the other eye. And this was about her, she's already had 2 DMEKs, band keratopathy removal, not an easy case. And
Not
she's a very active woman and still working. And so we want to try and improve her vision somehow.
So here's what the audience thought. In first place, we have repeat the DSAEK using an ultrathin graft. In second place, we have exchange it for a DMEK with pupilloplasty. And in third place, DSAEK with pupilloplasty. And I'd like to get the opinions of others on the panel of what they would do in such a case. Perhaps either Dr. Chu, Dr. Chan, Dr. Singhal.
I think, back to what Alan mentioned earlier, you have to really do what's most comfortable in your hands and what you're used to and what's best for this patient. The patient is monocular, you want to give them the best outcome. And for each surgeon, it's really what you're most comfortable with doing. So if you prefer doing DMEK in this case, I think, that's what your go-to would be. If you prefer doing DSAEK, you're more comfortable with DSAEK, I think that would be what you would offer. One reason for doing, I think, DMEK in this case is, obviously, Alan mentioned already the better, less chance for rejection. But I think an important thing is this eye's had quite a bit of surgery already, and you look at the limbus, and when you have your wounds there, if you do a DSAEK, you'll have to use a larger wound. With a DMEK, you can use a 2.2 or 2.4 millimeter wound, and they'll close a little easier. And you also have to consider that there's going to be a lot of retrocorneal membranes, especially in the peripheral, to where the failed DSAEK is when you're doing your stripping. You also have to take into account that there may be some membranes that go to the into the angle, so you have to be very careful when you remove those retrocorneal membranes, which you should. But you want to make sure that you do not cause a disinsertion of the iris body, get a significant hyphema, and those are other complications that can happen. So, I think in these cases, I would probably start hoping to do a DMEK, but after I do my stripping and I remove the transplant and then remove the retrocorneal membranes and see what we have, depends on what we have there. And at that point, I would either start stripping my DMEK if I feel it's favorable, or I might go to a DSAEK and cut my DSAEK at that point. But I would try to aim for a DMEK would be my best option, just whatever you feel most comfortable and best for the patient.
Wow, those are excellent pearls, tips, and comments. Dr. Singhal, we had an awesome day in the OR today with, you care to comment? What would you do in a complex eye like this eye?
I mean, I think really Hall has hit the jackpot. I think, as a surgeon, as a cornea surgeon, you really have to do what will give this patient the best outcome in your hands. I'm with him. I think I would do a DMEK. I think that if she's a monocular patient, I'm not really worried about, because it's not a vitrectomized eye, it's more an issue of the DMEK graft. One issue would be the fact that the DMEK is going to hit, is she aphakic or she's pseudophakic, I'm assuming.
She's pseudophakic, right? Yes.
Yeah. I mean, the issue here may be that I'd be worried about the DMEK graft hitting the intraocular lens, depending on the size of that pupil. So I may want to do a pupilloplasty at the same time after I strip that DMEK, the DSAEK graft. If there's, if the fibrin's not an issue, I may attempt to do that at the same time. But my first choice here would be a DMEK if I could do it. And just for all the reasons that Hall mentioned, which I think are great.
Thank you very much, Dr. Singhal. Excellent addition to the prior comments from Dr. Chu. Thank you very much.
Can I make a comment?
Of course.
Sorry, the elephant in the room here, we're missing that. That's that tube. And I think that whether you do a DMEK, a DSAEK, an ultra-thin DSAEK, or a PKP, that tube in the anterior chamber is going to reduce the likelihood of that graft succeeding. Just a question. The three previous grafts, they were in, the graft failed because of rejection or because of failure, because of the tube?
Sometimes I think it could be hard to differentiate. But I'll let Professor Rootman, since he knows the patient much longer than me, answer that.
Yeah, actually, I had her mixed up with a different patient. This woman had her surgeries originally in Moorfield. She's from Great Britain, and when I think I saw her the first time, this DSAEK was still functioning, and it was quite clear. And then her other eye went downhill, and so this is our first go at this eye. The other eye, we finally got it back up to scratch. But what was the question again? I'm sorry.
So, well, it was really more of a comment. I mean, this graft has failed 3 times because of the. I think we know that
the tube
that will fail with the tube, and especially I think the chances of an anterior segment tube are associated with more failures. I'm just wondering about the possibility of getting glaucoma and retina to perhaps do a pars plana vitrectomy and reposition that tube into the vitreous and let it settle for a while, and then doing a DMEK to, because we know that with that tube in the anterior chamber, the chances of longevity of that fourth graft, regardless of what kind of graft you're going to do, are not great.
Yeah, what our data showed is that the DMEKs do slightly better than the DSAEK. So as I've heard Clara say, is that we tell the patients that they're just renting the graft, that it's not there permanently. And, like we did one today, that this is every 2 years we've had to go back. The lady today was her third DMEK. So I think it makes sense that the pars plana tubes would be better for sure, but I'm not sure the data bears that out, because it's not just the physical banging up against the endothelial cells, but there's a total change to the aqueous environment that's probably toxic to the endothelium. I mean, these tubes are terrible, in my opinion.
Frank showed that there was a much higher, he attributes it to a higher protein concentration in the anterior chamber. I think the highest, you're going to get higher failure rates with an AC tube, less with a trabeculoplasty, and probably less with a tube in the vitreous. Mm-hmm. So, it might be worthwhile, as you say, they rent it, but every time you do, granted, you're doing less transplant, less antigenic material, but I think you still have to worry about repeated exposure to the immune system of lots of different corneas. It might be worthwhile trying to put that tube in the vitreous.
Yeah, I think that's a good point. But we keep the retina and glaucoma people very busy. And maybe we should be doing that on all of them before we, before we go ahead and do another transplant on them. Say, listen, make the situation better so that we can succeed for the patient, rather than having to go back after another failure in 2 or 3 years. I don't know what the right answer is. I'm not aware of any data that compares pars plana tubes to AC tubes.
So
one consideration too is, we're anterior segment surgeons, but we'd have to ask our glaucoma and retinal surgeons, what is the risk of doing that? I mean, they're going back into, we already have a tube that's functioning and working, and we know we can reproducibly do a DMEK in most cases. What is the risk of moving a tube from the anterior to the posterior segment? Is there increased risk for RD, or for suprachoroidal, or choroidal diffusions? That's another part of the equation you have to look at.
It's like playing Russian roulette. Like, how many times can you go? Who's going to be the one that is there when the eye finally has its terminal event?
In my fellowship, Chris Rapuano told me, you do not want to be known as the last person who operated on an eye that went blind.
So the question about, DMEK versus DSAEK, tubes, traps, those are excellent questions and comments. We don't have answers for all of them, but they say that a good question or comment is answered in the presentation's next slide, and we do address that in the next slide. But the first question, a pretty basic one, should we even be replacing a failed DSAEK with a DMEK? Well, our group recently assessed the outcomes of DMEK in eyes with the previous DSAEK, and although the entire cohort had a modest improvement in vision from 2400 to 2200, when assessing the eyes without significant visual comorbidities, the vision improved from 2140 to 2060, which is more than doubling of the angle of the vision. We therefore concluded in that paper that DMEK is effective for replacing a previous DSAEK, especially in eyes with good visual potential. And the second question regarding this patient is, should we be placing a DMEK in an eye with the tube, and how do these eyes do in the long run? Well, our group has published several papers assessing outcomes of different EK techniques in these eyes, and when you actually look at longer-term outcomes, as Professor Slomovic hinted to, you realize that these eyes have surprisingly low survival rates, with approximately 30% surviving at 4 years, whether they undergo DSAEK or DMEK, which actually now, we actually tell now to these patients that they are renting these corneas from us for a few years and that they will require repeat transplants in years to come. We've also been adding topical tacrolimus for these patients, as we found that rejection rates were higher than Fuchs patients that undergo DMEK. Regarding visual outcomes, the entire cohort had a modest improvement from 2400 to 2200, and as mentioned earlier, you want to know what the visual potential is. And indeed, when assessing eyes with good visual potential, you can clearly see that through the entire follow-up time, the DMEK group demonstrated better vision than the DSAEK group, as demonstrated in the graph on your bottom left. We therefore concluded that if there is indication of visual potential, there is benefit in performing DMEK in eyes with a tube. And this patient also has a planned pupilloplasty. Therefore, question 3 would be, is it wise to combine pupilloplasty with the DMEK? And the truth is, we're currently assessing the long-term outcomes of DMEK combined with pupilloplasty, and we hope to report our results in the near future. So let's go to the case. Pupilloplasty was performed with a CIF4 10-0 proline double-arm needle. The needles pass through one side, then through the other, then pass through the lumen of the viscoelastic cannula to safely exit the eye. The reverse Stinsky hook is used to externalize both sides of the suture through a common paracentesis. In this case, a 4-loop single knot technique was used. The knot is then carefully internalized, and using intraocular forceps inside the AC and straight forceps outside of the eye, the knot is tightened until achieving satisfactory tension. Afterwards, intraocular scissors are used to cut the ends of the knot. These cases of failed DSAEK, as Dr. Chu mentioned, may have a membrane extending from the failed graft all the way to the anterior chamber angle. Therefore, it's best to score around the existing DSAEK before removing it from the eye to avoid intraocular bleeding. The viscoelastic is then removed meticulously, and then we stain with vision blue to confirm that there is no remnant decimate underneath that failed DSAEK. The graft is inserted, again, always paying attention to potential positive pressure in order to avoid graft expulsion, and we tie off the main wound to have good control of AC depth. We then turn the infusion on to flatten the AC while tapping to unfold the graft, and once the graft is sufficiently centered, we insert a small air bubble to lock the graft in place. We also use this air bubble to unfold the rest of the graft by pushing it in different directions. After we're satisfied with graft centration and unfolding, we expand the air bubble. In this case, we again used a 30-gauge needle on a syringe to enlarge our bubble and avoid leakage. In these cases, you can also place a wet Wexel over the injection site to prevent air and fluid from escaping during injection while exiting the eye. We then pump up the infusion line to increase our pressure for a few minutes to encourage adherence of the graft in this relatively soft eye with the tube. Just a reminder, her vision at baseline with DSAEK was 20/30. After the DSAEK started to fail, she dropped to 20/60. At 1 day, her vision is hand motion. At 1 week, she's 20/60. At 1 month, she's 20/25. And at 3 months, she's 20/20, doing better than she did when her DSAEK was functioning. So how safe is it to perform a Plana Infusion DMEK for complex eyes in the long run? And how does that compare to a DSAEK? Well, we recently addressed that question, and our paper is currently in press with current eye research. We found that although the DMEK group did have advantages in terms of visual acuity in patients with good visual prognosis, these eyes also had higher rates of both CME and retinal detachment. As such, this procedure is not absent potential retinal complications. Specifically, it's probably best utilized in eyes with good visual potential. So regarding the question, to DMEK or not to DMEK, based on our own results, I would say that for straightforward Fuchs or PBK, DMEK is probably the best way to go. Regarding eyes with tubes or traps, go for DMEK if there's good visual potential, and remember to warn the patient that they are renting the cornea. Look for synechia in these candidates because it must be addressed during surgery and may affect your decision whether to perform a DMEK or not. When it comes to vitrectomized eyes, you can consider Plana Infusion DMEK if there's good visual potential and you feel comfortable with the technique. I'll also give out a shout out to my older sister, Dr. Gisela Santeila, who recently reported that for aniridic or aphakic patients, the outcomes of DMEK are disappointing with a near 100% failure rate at 2 years. As such, for these eyes with no diaphragmatic support, avoiding DMEK is warranted. Hopefully y'all feel comfortable daring to DMEK for appropriate cases. Thank you.
That was great, Michael. Really well done. Well done. Thank you for putting it all together. What was really beautiful is you didn't just present a bunch of cases, but you really show that there's some thought process behind the whole thing and that we're really trying to learn from our experience and figure out what the best thing to do is. I would like to put in one plug though, is that I really find that DMEK in eyes that have tubes is actually easier than DSAEK. You know, it intuitively you think there's a tube there, it's going to interfere with the graft, but it doesn't. And it should be farther away from the tube because it's less tissue that you're putting in there. And plus, as Hall made a great point, is that these patients have been operated on so many times and they may not have a clear limbal area to go through. So doing a small incision is really, I think, beneficial. And I'm not as frightened about having to go back 2 years later in a monocular patient, you know, that needs a new DSAEK or needs a new DMEK because their last one has failed. So I see Hall agreeing with that sentiment. Alan, do you have any final comments?
I think, Michael, you did an amazing job, and it's really nice to be able to discuss this. I think a lot of this is work that we've published here, you, myself, some of them, you know, trying to answer these difficult questions moving forward. And I think that, Michael, you put it together beautifully. You really, we're looking for a how-to, which one, and there are a lot of questions. And as you said, it's good to have good questions and to try to figure out ways of figuring out how to answer these questions. And I have to say, the fellows have done an outstanding job, all of them, in trying to answer some of these difficult questions and leading the way forward.
Thank you very much, Professor Slomovic. I think that during this very unique fellowship, a 2-year fellowship at University of Toronto, we have exposure to wonderful supervisors and mentors, and we discover, many approaches. Everybody does things a bit differently. The way they think is a bit differently, where they place their incisions, whether to do a DSAEK, DMEK, put SF6 or air, suture the wound, yes, no. And I think that's, one of the many strengths that this fellowship brings. And I feel truly blessed to have, the opportunity to be exposed to EK in these very complex eyes with all the supervisors and surgeons in the program. So, thank you very much for everything that you give us, the fellows.
It's a pleasure.
Thank you, Michael. It was an amazing talk, Michael.
Thanks,
And
Michael. That was great.
Thanks, everybody. Have a good evening. And
Thank you very much,
happy
everyone.
Purim to those people that are celebrating.
Happy
Thanks,
Purim to
David.
everyone. And before we finish, we'll just mention that next week, same day, same hour, we'll have our junior fellow Larissa Govoa will be speaking on PUK. So stay tuned, and if you can please fill the evaluation form, we'll greatly appreciate it. And thank you all of you for attending tonight, and bye-bye.
Thank you very much, everybody.
Great job. That was awesome. Excellent presentations. Thanks, guys.
Thank you, Dr.
Well done.
Oh, Michael, nice one.
Thank
It was
you.
fantastic.
Bye,
Fantastic.
everyone.
Okay, goodbye.
Bye-bye.
Bye.